Behçet's disease or inoxablate purpura. Coming to the investigations, hemoglobin was found to be 12.5 gram%, total count was found to be 7,600, platelets 1.9 lakh. The complete blood count was found to be normal, blood group was B positive, ESR was raised. Coming to the urine examination, routine examination revealed albumin 1 plus, plenty of RBC and pus cells 2 to 3 per high power field. 24-hour urinary protein was 150 milligram. Malaria parasite was not found. The fasting blood sugar was found to be 100 milligrams per deciliter. The urea and creatinine levels were found to be within normal limits. The LFT was found to be normal. There was total cholesterol was 211 milligrams per deciliter. LDL was found to be 152 mg per dl. HDL 40 milligrams per deciliter. The PT and APTT were found to be normal. The BT and CT were also found to be normal. So a bleeding disorder is excluded. This is the picture of the X-ray of the patient. Here you can see a nodular tile-like lesion in the right lung field. This is the X-ray of the patient 1 month back, which is a normal X-ray. Coming to investigations, sputum AFP was found to be negative, gram stain CS no growth, urine culture revealed no growth, Mantoux test was found to be negative, ECG was found to be normal, USG whole abdomen revealed normal study, echocardiography, there was no regional wall motion abnormality, LVEF 70%, all walls and chambers were found to be normal, no pericardial effusion was noted. Then we investigated for the ANCA. C ANCA and P ANCA were both found to be positive. C ANCA 21.6 and greater than 3.5 was found to be positive, and P ANCA 23.40 greater than 9 is positive. Complement panel, C3 complement was found to be normal, C4 was found to be increased. This is the photo of the complement report. Then a kidney biopsy was done. Renal biopsy, glomeruli, they are in the range of normal size, no segmental sclerosis even in the juxtamedullary glomeruli, there is no collapse of ducts, capillary lumina are patent diffusely with single contoured basement membrane, spikes or pinholes are not seen in the basement membrane, tubules and interstitium appear unremarkable, no granuloma or eosinophils, vessels there is mild hyperplasia of tunica media, there is no focus of vasculitis or luminal thrombosis. So the impression of the renal biopsy was light microscopy shows only 3 glomeruli, no abnormality in these glomeruli, no evidence of interstitial inflammation. IF4 doesn't have glomeruli. Upper GI endoscopy reveals cardiodenum, ureus test of H. pylori was positive, otherwise normal. Investigations of HIV, HBsAg and anti-HCV were found to be non-reactive. The ANF was found to be negative, RH factor negative, CRP was found to be positive. Final diagnosis was granulomatosis with polyangiitis, vaginal granulomatosis. The points in favor of the diagnosis were hematuria and hypertension, which is a sign of hematuria was a sign of glomerulonephritis, epistaxis, nasal congestion, oral ulcers, hemoptysis, ESR was found to be increased, and P ANCA and C ANCA were positive. Since the patient had features of upper respiratory tract infection, lower respiratory tract infection, and features of glomerulonephritis, since this triad was present, we diagnosed this case as a case of granulomatosis with polyangiitis, that is vaginal granulomatosis.
So we have contacted, you have asked to repeat this more because initially you have we may not get this. We have asked, but after 6 months we will repeat this.
CMK was highly.
Sir, one thing is very much absent. What is the CT scan of the chest of this patient? You have got the patient having nodular lesion, having renal involvement, and diagnosis no CT scan. How it is possible? You have to have it. You are showing there is a nodular lesion. So what is the problem? You get a CT scan of this patient at least.
We have planned for we have advised him for a CT scan of this patient.
Do you think the kidney biopsy was adequate?
The kidney biopsy was inconclusive. Kidney biopsy was inconclusive.
You think the material was adequate?
And the material was not adequate. Because the immunofluorescence score doesn't show glomeruli.
There should be minimum 7 glomeruli should be there at
7 plus glomeruli. You have got only 3.
So it can be
in case you do not want to get another kidney biopsy, go for nasal mucosal biopsy as well. That's a very good idea where if you find granuloma, along with high this thing, ANCA. So I think this is sufficient.
Clinically,
Yeah.
what Wisner reported the case, 2 or 3 points are very much suggestive of upper involvement, but there is no perforation, no, because more and progressive this, even no the nasal perforation, nasal bone, all are reported. We have to, Sianka is highly clinically fitting. What Wisner reported in first 2 cases, out of 3.4 points what we are getting. But sir, regarding a CT, generally it is a small nodules. What in our X-ray, but we have to confirm it is a benign nodule like coin shadow.
So,
Like.
but you have to buy CT is the better way. And
Yes,
what you
yes.
have shown the
Would
X-ray.
you agree? We have planned for this thing, would you agree? I know.
Sometimes it is very much confusing to differentiate between SLE and Wagner in this picture. But the male patient,
Yeah.
epistaxis, these are in more favor of Wagner.
But Sianka sir will, high Sianka will never in SLE. And regarding sir Wisner, this name is replaced by now GPA. GPA because Wisner was a German and American don't want to calling him as a Najib people.
Yes.
So they have changed the name as a GPA, granulocytosis with polyangiitis. So otherwise Wisner's syndrome itself is a clinical spectrum.
Okay, next case. Very good.
The treatment,
Now,
treatment sir, we